reconcile myself to Oscar Wilde, say the one thing worse than being tweeted about is not being tweeted about. So that's the good thing going on. So moving on from, I guess, what is, I think we all in this room would recognise as a fairly grim picture in terms of the health of people with learning difficulties and the impact on their lives and indeed deaths, to moving on to think about what the evidence says about what we can do about those health inequalities that people experience. And I guess in terms of the research evidence, there are kind of a range of strategies which we can look at in terms of trying to improve the health of people with difficulties as a population. So the first area where there's actually been the most research around is to try and help people live healthier lives. So this is particularly for people who are adults who are already known to specialist services, about trying to improve people's nutrition, trying to help people to take more exercise to live healthy lives, try and reduce or indeed increase people's weight. There's some research around that. I guess two observations for me. One, they're typically only with the 20% of adults with learning difficulties who are known to specialist services. So we estimate that about 80% of adults with learning difficulties who are identified as such in education services, in schools, don't then go on to keep that label or that flag in adult services. So we know very little about the 80% of adults with learning difficulties, people with mild and moderate learning difficulties, for example, people who are going to be at high risk in terms of all the socio-economic factors we talked about. Those people are invisible from these kind of interventions that focus on services. So typically, for example, people in social care, try and improve diet, try and improve activity, exercise. What we know about those studies, and there's been a number now, is that they have some impact in the short term, but their long-term impact is unclear. And they're often, actually, they're very difficult to do because the routines and the practices within social care and other services stop those things happening. So they stop people being able to turn up to an appointment because there isn't a member of staff to come with them. One of the things about Winterbourne View, it's not the most shocking thing about it, but one of the shocking things about it is where it was, on an industrial estate. We're talking about services that are on industrial estates near Ring Road. How are you going to promote healthy activity? How are you going to walk to the shops? How are you going to buy your fruit and veg? How are you going to cook that if you're living somewhere like that? So, the research that we know about trying to help people living healthier lives show that it has some limited impact, but it's hard to do. It's a real kind of extra effort for people. Better health services. We know there's a major push, and this is obviously really important, about primary care and GPs, about accessing care and hospital services too. All those things are very important, but one of the messages for me of kind of the rainbow, which Sue talked about earlier, is that health services is one part of a person's life. In terms of a person's health, that's one element, but it's not the only element. So it's important that we get health services right, but that won't, if you like, solve the whole issue in terms of improving people's health. But vaccinations, for example, flu vaccinations, we don't know much about that. There's some stuff on health screening that shows that people with learning difficulties are less likely than other people to get access to things like cancer screening, for example. And again, there's kind of work underway from a range of people to try and improve that. We also have good evidence on health checks. We know that annual health checks for people with learning difficulties identify a wide range of unmet health needs for quite a large proportion of people. We also know that those health checks then lead on to more testing and health treatment as well. Sometimes these are for really kind of big ticket stuff, really important things, or really life-threatening things. But sometimes things like impacted earwax, for example. Health checks identified in a third to a half of people with learning difficulties. Impacted earwax is a real thing. It's not life-threatening, it's really easy to sort out. It's a one-off thing, no medication, nothing dangerous. But imagine what impact that has on someone's life. If you can't hear properly due to impacted earwax, that's going to have a massive impact on your life. So we know that health checks do have an impact. We know much less about, I guess, broader public health interventions. So things like making the healthy option the easiest option. So, for example, in terms of how people got here today, London's quite interesting actually. I live in Kendal in Cumbria, so we don't really have buses, so we have to walk everywhere, or we have to drive. In London, because of I imagine driving is a nightmare, expensive, and public transport is much easier, probably many more people use public transport than walk. There's some stuff in public health that's starting to be very interesting about how you design environments, how you design neighbourhoods to try and make, if you like, the easiest option for a person, the healthy one. So public health have arranged some things like that. It was like clean water. We don't choose whether we have clean water or not. It just comes out of our taps. We don't have to make an effort to have clean water. When it comes to getting clean water or going to get filthy water from the river, it comes out of the tap. It's the healthy option, is the easy option. And we need to think about other aspects of the way that people live their lives to try and make the easy option the healthy option, rather than the easy option the unhealthy option. And finally, in terms of the list of bad things that happen to people, that are more likely to happen to people, we need to think about how can we stop those things happening? How can we stop discrimination? How can we stop bullying? What can we do about people's economic circumstances? What can we do about employment? What can we do about isolation, relationships, friendships? All those things are really important in terms of people's health. But in terms of research, we've got kind of scattered research, but not a huge amount. Sorry? Oh, sorry, am I quiet? Is that any better? Green.
Press it to make it
Oh, pressing. No, you told me about pressing. Well. So at the back, we missed all that.
You might want to read that, Chris.
I'll read it, but not now. What did I say? I can't hear. Oh. Funky down, thank you. The word the funky down is thank you for pointing that out. And maybe earlier would be even better. So there. See? I'm a convert. So I want to talk to you about the health impact of pyramids. So this is something that's kind of a broad public health way of thinking about public health interventions and what impact they have or don't have on the health of a population. So at the top, we have counselling and education, so the kind of things about kind of improving your weight, exercise programs, those kinds of things. Those are kind of things that require a lot of effort and active engagement. Then going through that, we have clinical interventions, which are kind of health services of various kinds. Then we have the long-lasting protective interventions, so things like annual health checks, where having a check potentially helps kind of fend off some longer-term kind of working up of health impacts, which would then require clinical interventions. Then the things I've talked about changing the context to make individuals' default decisions healthy, so making the healthy option the easy option. And then at the bottom, we're talking about socio-economic factors, employment, poverty, housing, those kinds of issues. It's a pyramid for two reasons. On the left, you'll see it's a pyramid because the further you go up, it's harder work for the individual. So it's much harder work for any individual to get involved in a physical exercise program than it is to get clean water out of their tap, for example. So the further you go up the pyramid, the more active involvement it takes from a person. That means it's more difficult to sustain because it requires that extra effort over and above your daily life. On the right, you'll see it's also a pyramid because interventions at the top are much more expensive, they're much more intensive, and so therefore they only operate on a relatively small number of people. So when we talk about the programs in terms of physical exercise or in terms of weight loss or in terms of nutrition, again, they're only for a fairly small number of the people who are the fairly small number who are in social care. So those interventions are never going to impact on the whole health of the whole population of people with learning difficulties. They're too intensive. They only work for the group of people who maybe have informed consent and who can really kind of actively engage and understand the materials. So what I take from this message is that in kind of public health research, we're very much focused on the top of the pyramid. And we've learned some things there, but we've also learned the limitations of trying to work at that level. Those things are valuable and important, but I guess they're not the only picture. But we need to start thinking about, health checks are a great example of a kind of long-lasting protective intervention. So working on making those routine, working on how we can get GPs to think about expanding out health checks, so they're not necessarily learning disability deaths health checks, but they're health checks that are done regularly on people, on the 80% of people who aren't known to services. We can think about that in terms of health literacy, for example. So we know that 20% upwards of the population generally have trouble with things like when you get a letter from the GP. They have trouble with forms, they have trouble with numbers. That would include people with learning difficulties, but it's a much bigger group. Now surely any kind of health service needs to get themselves geared up to address the health literacy of 20% of people across the country. And if they sort that out for 20%, they're also sorting out for people with learning difficulties, or the other way around, as we keep trying to say. If you can sort it out for people with learning difficulties, it's going to help a whole lot of other people too in health services. So what can we do in public health terms? I would say I think we need to think about the health of everyone with learning difficulties. So we know about the 20% of people who are known to, 20% of adults who are known to specialist services, but there's this much bigger group who are at risk in terms of all the kind of socio-economic factors. We need to make sure that they're being looked after properly. We need to really make sure that health checks are really rolled out and really happening routinely for people. We need to think about health screening, really making sure that those things happen routinely for people. So again, making sure that all the big national screening programs, why can't they be routinely easy read, for example, to everybody? I'm sure it would help me. If I got a screening letter, I'd be much more likely to understand what's happening in easy read than some of the ones that come through the door that are the way they're written now. We need to think much more about how we can make the healthy option the easy option. So how can we make it much easier for people to live healthier lives rather than unhealthy lives? Do we really have to drive everywhere? We need to think about the locations where people live. We need to think about what access that affords in terms of diet, in terms of activity. We need to think about making neighbourhoods safe for people. If somebody doesn't feel safe going outside of their door, they're not going to go out. And in public health terms, we need to think about more work, better housing, thinking about hate crime and how we can stop that, and think about more money for people, particularly in terms of employment, proper paid employment. And I think this not just because I'm here this morning, because we're here this morning, but I think the HEF is a great tool for that, because I think what the HEF does is it takes some of this agenda, it puts it into a tool that's really easy and straightforward for people to use, and it hopefully opens people's minds to the range of issues that there are and the range of issues in which they can address them. So just to finish off, we know that health inequalities are, to a large extent, avoidable. Most of the health inequalities that people with learning difficulties experience are not due to their learning difficulties. There are relatively few kind of syndrome-specific health problems. There are some, and they're very important to certain groups of people, but in terms of the whole population of people with learning difficulties, many other things are important. We know that poor health, as Sue was saying, doesn't just have an impact on the health box. We all know that poor health impacts on every area of our life, and we need to really get to grips with that. And again, I think the HEF is a great tool for doing that. We know that poor health costs health services money, we know it costs social services money, it costs lots of people money. And we also know that poor health is not just about health services. So it's really important. People can get a really poor deal in health services, and we need to make sure they get a good deal. But there's also the whole range of issues which means why they get into those health services in the first place that we need to understand. And health is everyone's responsibility. So this is what the World Health Organization says: why treat people without changing what makes them sick? And I shall leave it there. Thank you.